Thank you so much for the kind invitation. It is a great honor and pleasure to be here, to stand here together with my colleagues and friends Eike Pichowiak and Thomas Dubrotsky. And it is really a pleasure to be invited by the Association of Thai Interventional Neuroradiology and the Radiological Society of Thailand and our friends and colleagues we met over the last years that made this possible and happening. And thanks so much for the kind introduction. And now I can start the scientific part and the medical part. I am a neurosurgeon and I worked for over 10 years closely together with Eike and Thomas in Bern. And since a couple of years I'm the chair in Freiburg. But you have to know Freiburg and Bern are very close together, not only in our minds, also geographically we are all less than 2 hours away by car. So we really still are a kind of community and friends and are working together. And we have a common hobby and a common mission, which is the disease of spontaneous intracranial hypotension, which was very, very rare in the beginning. And we had several cases a year in the beginning. We're very excited to have the first patients. And nowadays, it's daily business. So we really treat, I have a full ward only of patients of SIH, and we treat several patients each week. And so we are happy and proud that I can give the introduction to SIH and the clinical presentation and just the basics. So SIH wasn't on our map and our list a couple of years ago, and now we have even big reviews in the big medical journals, in the New England Journal and the Lancet, and it is kind of a new hot topic in the neuro universe. And it's good because we can also treat it, and you can treat it. We come from Europe, we come from the center of Europe, and Freiburg and Bern, as I told you, are very close together, less than 2 hours by car. And this is the hospital, the town I'm working in currently now. This is called Freiburg. It has only 200,000 inhabitants, and this is how it looks like. And the highest building is the church. There are no skyscrapers, so it looks completely different. And we have a small Black Forest, as it's called, and if I climb on top of the Black Forest, I can almost see Bern and the Alps and look to Switzerland. This is our hospital, and for German circumstances, it's quite big. This is only neurology, neurosurgery, and neuroradiology in one building, and we do have 6 neurosurgical theaters each day, so it is the biggest center in Germany. This is the center now from the ground. Coming to the disease, spontaneous intracranial hypotension is an orthostatic headache syndrome. So in the beginning, you really can recognize the patients quite easily. They have a headache while standing up or while sitting up that is immediately in seconds or minutes relieved when lying down. And why does this come from? And it's a very physical disease, so to say. You have a hole in the dura mater, and CSF is oozing out. So you have a hole in the dura mater at the level of the spine. CSF is oozing out, and then literally the brain is kind of sagging down. It's tearing on the veins, it's tearing on the cranial nerves, giving you all the signs and symptoms. So once again, you have a hole in the dura, CSF is oozing out here at the level of the spine. Yes, there's a pointer here, and the brain is shifted downwards. And it's so to say a spinal disease, and you treat it at the level of the spine. And there's a long history of how to classify the disease. What is it? Is it a syndrome? Is it a spectrum? Is it a disorder? Is it a disease? And this shows that the disease is rapidly evolving because our knowledge is evolving very fast. And the International Classification of Headache Disorders, it is a headache disorder, have been the first to classify this disease as, firstly, an orthostatic headache with a low pressure, a low opening pressure during a lumbar puncture, and some evidence of CSF leaking on imaging. And it's also in the name of the disease, intracranial hypotension. But nowadays, since we know more, we first know it's probably a misnomer because most of our patients do not even have intracranial hypotension. And you see that the opening pressure has a faint writing here because we do not even do lumbar puncture in these patients for diagnostic reasons anymore. There is no need of doing that. And even the orthostatic headache is in parentheses because sometimes you don't even have an orthostatic headache, and sometimes you don't even have headaches at all. So you have some symptoms, no need for a low opening pressure. So these days, it basically comes down that this classification is kind of arbitrary, and to be honest, no one is using it anymore. So what is SIH? It's an imaging disease. Of course, you need to do a proper history and physical examination, but really when it comes down to classify the disease and to diagnose it, it's an imaging disease. And evidence of CSF leaking on imaging is now abundant with the prevalence of MRI. And there are always two questions you need to ask yourself. The first question is, does the patient have the disease at all, SIH? This is probably rather easy, and this is an imaging disease, most likely of MRI. And Eike and Thomas will discuss this extensively in the following talks. And the second question, where the leak is a way more difficult question. And again, Thomas and Eike will give you the details. But nowadays, imaging is the basis for diagnosing and also for understanding what's going on in SIH. And it is intracranial hypotension, it's spontaneous intracranial hypotension. So the symptoms are quite similar, but we need to discriminate and discern spontaneous intracranial hypotension from post-dural puncture syndrome, from post-surgical CSF leaks, from overshunting, or from fistulas and leaks that happens at the level of the brain, of the skull base. These rarely or practically never cause SIH, they cause meningitis, and you have to take care of these patients as well. But this is known since decades. And so coming to the clinical picture, to the clinical presentation, it is the mainstay is orthostatic headache and symptoms of irritation of the dura, of the cranial nerves and the brain itself, causing headache, neck pain, photophobia, nausea, and also cranial nerve deficits. When you just tear on the cranial nerves, you have double vision, and even almost all patients complain about tinnitus, or hearing problems, and you can explain it with the brain is sagging down. And this is very important, that these very clear orthostatic symptoms only happen in the beginning of the disease. And the disease often takes very long until we diagnose it, weeks, months, even years. And then the clinical picture really faints and blurs, and it's very diffuse. So imaging is the key, especially in patients that have long-standing symptoms. So again, orthostatic headache, and this imaging is way better because the headache is probably more a neck pain or a headache in the top of the head and in the back of the head, not so much in the front of the head. And you have many symptoms all over. So it's a very interesting disease. What symptoms you can have clinically. And if it's getting complicated, you need to have a way out. And so the key question to your patients is, how was it in the beginning? And many patients with SIH that do remember the specific day and date when it all started, they say, suddenly, this day in April, my life changed and everything was different. So at that time, it was clearly orthostatic, and when I laid down, the headaches and my symptoms resolved. So the beginning of the disease is key when you think about history taking. Before the invention of MRI, it was so rare that you could have published any case of SIH. And nowadays we have a rough estimate how prevalent and what's the incidence of this disease. And we probably think that the incidence of the disease is almost 5 per 100,000 person years. So it's in the same range as subarachnoid hemorrhage. It's probably more, it happens more often than gliomas, and almost as often as multiple sclerosis. So it's not super rare. You will encounter patients in your further practice. It is a disease of the young, of the working population, a little bit more prevalent in women than in men. And the key problem is that probably you, the interventional neuroradiologists and the neurologists, that come to such meetings, you recognize there is something new going on. We need to recognize, but out in the fields, as we say in a community hospital, neurologists and all general practitioners do not really recognize this disease. And they say, oh, come on, it's just a headache. It's not just a headache. It's way more than a headache. And our patients, they lose their jobs, they lose their families, and they even lose their lives. So it's really, and I come to this later on during the talk, it's really a disease that's affecting our patients heavily. This is just one more clue to pathophysiology. You have to remember everything happens when they stand up. CSF is oozing out, and even the optic nerve sheath is collapsing, which nowadays, there's a revival of this. In difficult cases, you can look at the MRI and don't forget to look at the optic nerve sheath. It gives you a clue whether the patient has the disease or not. Now, this is a prototypical image. You have pachymeningeal gel enhancement, you have subdural effusions, you have downward displacement of the brain. And I always say, if you have an image, such an image, and you have a patient with a GCS of 15, so no fever, no complaints while lying down, there is no differential diagnosis. This is not infection, this is not cancer. If the patient is awake and has no symptoms while lying down, you need to go to look for the leak. There is no differential diagnosis. Then you have imaging of the spine, where in most of the cases, if you don't have a fistula, you have SLAC positive patients, meaning there's CSF outside of the thecal sac where it doesn't belong to. You have the clear diagnosis. This patient has SIH, period. And Ike and Thomas will elaborate on this. And over the last 10 years or so, we found that probably 99% of our patients you can classify into one of these three leak types. Type 2 leaks, which are lateral leaks, almost always happening in, next, or around the exiting nerve root sleeve. The ventral leaks, which happen in the ventral side of the dura, and very intriguing, very curious, a type of a leak that was discovered 10 years ago, direct CSF venous fistulas, a direct communication of the CSF space to a vein. So it is, in a sense, also a neurovascular disease, and giving us and you the opportunity to treat this endovascularly. This is a new treatment. And this is just another scheme that you can classify type 1, type 2, and type 3 leaks nowadays. And I will skip that because this is a topic of Ike and Thomas, but really for the second question, where is the leak? You are key. Interventional neuroradiology and dynamic studies are key, and it is not easy. It is not easy to find these leaks. But when you have some tips and tricks, then it will become easy and it will become part of your daily practice. And it is a fast disease, so to say. This is just one frame and another frame, and you see that the contrast is traveling along the thecal sac, and suddenly there is a breach, there is a hole here at the dura, and the next frame, it's spreading almost as fast as the contrast is running intrathecally. So you need to be fast and need to do dynamic studies that you see where the origin of the leak is, not where the CSF is flowing to, but where it comes from. And we were lucky, it was really just a hobby. I'm a normal trained brain tumor surgeon, vascular surgeon, and these days I have our own ward only full of patients with CSF diseases. And again, Ike, Thomas, and myself, we always invite you to come to Europe, to come to Bern, to come to Freiburg, and to join us for treating these patients, to learn some tips and tricks, to join diagnostics, to join surgery. Come to our place. I have a huge team only of neurosurgeons, radiologists taking care of patients with CSF diseases and providing them with this beautiful imaging. Just briefly to the three types of leaks, you will hear more from my speakers then. Ventral leaks usually are due to a tiny little microspur that is cutting the dura like a knife, and it does look like this at surgery. I'm opening the dura from the dorsal root, and I cross the dura to the ventral side, and you see this oval-shaped tear in the dura. Now I'm removing the microspur, which is smaller than a rice corn. It's very, very tiny, but it's the cause of this disease. And in the beginning, I sutured it. Nowadays, I just patch it with Tacosil from the outside and from the inside. And the procedure takes probably 50 to 70 minutes, skin to skin, and it is very fast these days. I need to know where it is, so radiology is key. There's no room for explanatory surgery. I need to know where it is. And what we do see, what you don't see on imaging, are these membranes. This is a microsurgical finding, and you see many of these membranes. So this is the thecal sac, this is the exiting nerve root. You have these black structures are neomembranes at the dorsal side, and these are tiny little membranes you can see through confining the extrathecal fluid. This is what is at the rim of these slacks. It doesn't ooze out into the soft tissue because there are tiny little membranes that we see at surgery, and this is probably key why blood patching and percutaneous procedures do not work as well as surgery. Then we have the spinal meningeal diverticulars or cysts that you can see here, and this is also a surgical imaging. That is the arachnoid, the cyst, and it is very thin. You can see through. It looks like arachnoid. Why? Because it is the arachnoid that is pouching out. This is a different patient we operated a couple of weeks on later, and it looks thicker, but it is only the scarring that happens over time. And here the key is that the origin of the disease, again, is a tear in the dura, and the CSF is oozing out next to this herniation of arachnoid. Imaging is getting better and better, and nowadays we get imaging from Niklas Lutzen in Freiburg. This is so beautiful. So you can see here, this is a cone beam CT. This is the root with a little CSF above and below the nerve, and 2 millimeters below there is a tear in the dura, and this is exactly what I found at surgery. So this is the nerve root, 2 millimeters below, there is a tear in the dura, and this is the outpouch arachnoid. So this is just beautiful how good imaging is getting these days, although with a Siemens machine that helps me doing surgery. And very intriguing, the CSF venous fistulas only discovered 12 years ago by Walter Schieving in the LA. So we have a disease which is a direct connection from the cecal space to the vessels. If you have some tips and tricks, and Thomas will introduce these tips and tricks to you, it's also very straightforward to diagnose this disease and to be able to treat it. So, coming back to the symptoms, what is SIH? Concerning headache, it is a severe headache disorder. And now to give you some numbers, there's the HIT score that is classifying and quantifying the headache, the impact of the headache on daily life. And with patients with SIH, you are way above severe impact. So you have a mean score over 64, and you can treat these patients. And the delta you make, the impact you make with treatment, either endovascularly or surgically, is huge. So you are way better than the headache doctors treating migraine or tension type headache. The effect of treatment is tremendous. And there are not only headache symptoms, there are also symptoms from the depressive world, so to say. If we apply scales and scores measuring depressive symptoms, you see that over 2/3 of our patients with SIH have depressive symptoms. This is changing rapidly after surgery, but you also recognize that probably 20% every 5th patient is not really getting back to normal. Despite we closed the leak and we found something physical and we close it, this is tough to understand as a surgeon. If you close the hole, that the patient doesn't get really healthy. And to tell you what's the main reason is not the level of the leak, not the type of the leak, it's timing. It's timing. When a patient comes only months and years to you, it's very difficult, or it's more difficult to make them happy and healthy again. So timing is key in this disease. Quality of life, the typical, to give you some numbers from Germany, so SIH patients are way more affected than patients with breast cancer, advanced renal cell carcinoma, or even head and neck cancer. So it affects quality of life severely, and again, you can make a huge impact and restore quality of life with a one-day procedure and simple treatment. To give you some more numbers, we now try to qualify or to quantify SIH in a better way that we compare it to different diseases out of our neurology spectrum. And there is a disability weight for SIH. It is not made by in sessions that they do the global burden of disease study, but with prompts, with patient-rated outcome measures. So we asked our patients, and roughly we can say that SIH affects our patients probably as severe as moderate multiple sclerosis, metastatic cancer, or renal failure patients on dialysis. So this is really a disease that is a substantial disease of non-fatal health loss in ongoing SIH. Is it a dangerous disease? I told you, yes, they lose their jobs, they lose their families, but they can also lose their lives. So this is a typical patient that was treated in my department, in the neurology department. What is it? It is SIH, of course. Bilateral hygromas, 52-year-old young patients, orthostatic headache, completely symptoms-free while lying down, you see in the brain sac. And we did the first blood patch, a neurologist did the first blood patch, and tell her to go home. This was in the beginning at my service there, and she came back by helicopter with a severe stroke and bleeding in the thalami and ischemia in both occipital lobes, and she had a horrible outcome, and she had even some brain hemorrhage in the brainstem from severe brain sacking. So it is not a harmless disease, and you can even die from SIH. And this is not just one case report. The literature is full from patients dying due to SIH. So don't say go home, lie down for a couple of weeks or months. Treat them early. It's a serious disease. And since now we nowadays know what's the origin, we need to try to find the origin, continue to work up until you refine the leak. And if patching fails, you can or should continue with surgery, and nowadays also with endovascular occlusion of CSS venous fistulas. Another important impact, how SIH impacts our patients, is of course their ability to work. And I told you that these patients are our age, working population, and these are 200 patients from Freiburg, and all of them did work before the disease started. After the start of the disease, 96% of them were not able to work as before. So 2/3 were not able to work at all, and 1/3 had reduced working hours, or they took a pillow to work, to lie down every other hour. So it's really affecting our socioeconomic system as well. And after surgery, we can change it, we can restore it. And again, you see, we can restore it in 2/3 of the patients early on, and even after 6 months or longer follow-up, many of them, the green ones, are back to work, but still 20% or so, we do not manage to make them completely healthy again. And this is again the subgroup of patients with years of symptoms and years of disease burden. And we do not really understand up to now why. We close the leak, there is no more CSF oozing, and they do not really get healthy. So there's something ongoing metabolically or functionally. We need to understand better in the future what's going on here. This is just an example. It is, of course, a huge cost for society if we don't treat these patients, and it amounts to 700,000 euros or so after a couple of years. So really, it's also, of course, impacts social life. The natural history of SIH is important. I was referring to this several times now, and we started kind of, from our gut feeling to discriminate patients with acute disease, so 3 months, 10 weeks or so, subacute, less than 1 year, and chronic, more than 1 year. And this seems to be, turns out to be very important, since first of all, the history and the complaints are changing. I told you in the beginning of the disease, it's easy to discover because the patients tell you, oh, I have a severe headache while standing up, and it immediately goes away when I lie down. After 3 months, this is blurring and fainting, and patients can even have a more severe headache while lying down. So it's really a changing, an active, a dynamic disease. And this impacts the prognosis and outcome. So you have the highest chance to completely heal your patients when you are early in the first 3 months, and the chances of getting a full recovery diminish over years. Okay, so be early, and this is not only true for surgery, this is only This is also true for interventional neuroradiology. If you treat a CSF venous fistula, try to treat it early, because it's the only modifiable factor that has an impact on outcome, is time to treatment. This is a series from Wojciech Będzicki, who I think was the first who did the endovascular embolization of CSF venous fistulas. So we made a consensus meeting in Europe and published the first kind of guideline paper, and we strongly advise to take this disease seriously. It impacts quality of life, headache, social system, and the only modifiable treatment factor is time. So be early. Don't tell them come back 6 months later. Treat early and escalate the invasiveness of your treatment and diagnostics early on, meaning in the first weeks. There is more in SIH. The origin of SIH are spinal CSF leaks, and there are so many diseases that we just learning now that are related to spinal CSF leaks. So, of course, spontaneous intracranial hypotension, but also subdural hematomas. Way more subdural hematomas than you think, and we do a prospective study right now, and the first results are mind-blowing. Way more subdural hematomas than you believe are due to spinal CSF leaks. We also have superficial siderosis and also a kind of spinal dementia, and also idiopathic ventral spinal cord herniation, which is called idiopathic, which is really the sequelae of a spinal CSF leak. And just the spinal cord is trying to close the tear in the dura, and is then kind of sucked out of the thecal sac, and it ends up with a ventral spinal cord herniation. It is not a genetic disorder. This is just a sequelae of a spinal CSF leak, a type 1 leak or ventral leak, that's all. And superficial siderosis, the classical type of superficial siderosis, the infratentorial type of superficial siderosis. When I was younger and was trained, my neuroradiologists did whole spine angiography to find some vascular disorder. Nowadays, just look for the leak. We do know that infratentorial superficial siderosis is a sequelae of a spinal CSF leak. And then there's a very intriguing disease, again, found by Walter Schiewink, severe, very, very severe brain sagging. You have behavioral variant frontotemporal brain sagging dementia. It's a horrible disease. Patients die, they are severely demented. And if you look for the cause, we found, or Walter Schiewink found, that almost every other patient, 43% of these patients with severely brain-sagging dementia do have CSF venous fistulas that you can treat endovascularly or surgically, and you can cure some of these patients with this severe dementia syndrome. So very provocative. There's also a form of spinal dementia, and that is related to CSF leaks. And it is not only severe dementia, it is also mild cognitive deficits these patients have. And we are trying to test this systematically right now in Freiburg with the help of neurology. We do standardized testing in all patients with CSF disorders, trail-making tests and MOCA tests. And even if we measure it the day after surgery, so when there's still general anesthesia and we have intubation narcosis, so to say, still the day after surgery, they are way faster in thinking and cognitive function and executive disorders. So this is really impressive. And since we are a referral center in Freiburg, many rich people and very well-educated people all over Europe and all over the world come to our place because they look it up in the internet, this disease. They don't believe they're treating physicians that, oh, you can do nothing, you can do something. So really very intelligent patients come to us, and they're able to run a company of 10,000 people while lying down in bed flat. And once they sit up, they suddenly have slurred speech and cannot think so fast. And you can quantify this. And when you close the leak, you reverse this. So it's also a syndrome of mild cognitive deficits or even of dementia, if you want to say so. And now we try to analyze this. Eike and Thomas will introduce the Burn score to you, where you have real, you can see with your naked eye on the MRI that the brain is sagging down, and you can quantify this. But probably there are more subtle changes going on within the brain. So we call it tectonic shifts, that not only the whole brain is sagging down, but also within the brain there is some movement. And we try to quantify this with some sophisticated AI. I do not understand, but my young colleagues in Freiburg, they developed this. And now we have a system to measure these inner movements within the brain, and we clearly can see, which is obvious, that the ventricles enlarge when you close the leak, and the sinuses shrink. So it's the reversal of the brain's Burns curve, so to say. But you also have within the brain tectonic shifts that you can clearly depict, and these are measurable. And if you concentrate where is the highest strain within the brain, it's happening in the temporomesial structures, where the hippocampus is, where the amygdala is, where the fornices are. So probably it is a mechanical problem that relates to cognitive disorders. This is very interesting, and just on the way to be published. And there's also, we try to find the proteomics of the CSF in SIH, and these are the first results, doing mass spectroscopy of CSF samples of patients with SIH, and there seems to be, there's a whole plethora of proteins that is upregulated, and so probably when this happens over years, we have a kind of a metabolic syndrome, and this is the reason why with a simple surgical closure of the dura, we cannot cure all our patients. So there is something metabolic also going on. So spinal CSF leaks are really a wonderful disease. There is so much going on. You can have a plethora of symptoms, a plethora of other diseases like brain sagging dementia, spinal cord herniation, superficial siderosis, subdural hematomas, and of course spontaneous intracranial hypotension that are all related to a duropathy, to a hole in the dura, or to a pathological connection of the CSF space to the vessels, a neurovascular disorder. In Europe, and I'm lucky to be the chair of the CSF fluid section, we founded the CSF fluid section only 4 years ago. And I do believe that CSF is in the next 10 years, so to say, we will have lots of low-hanging fruits for you to publish on, low-hanging fruits to find new diagnostic ways and new therapeutic ways to help our patients. So I think there's much going on in the cerebrospinal fluid, so to say. And just to give you the latest results from the literature, Wouter Schiewink published a paper that we now also have probably a genetic disease that is a mutation in some exomes of connective tissue that are related to spinal CSF leaks. This is for sure not monocausal, but is another piece in the puzzle of how we understand this disease. But to give you a simple summary, so to say, over the last 10 years, we learned tremendously. We learned a lot, and now we have first guidelines. And to put it together simply, we have clear imaging findings. Thomas and Eike will introduce this in more detail to you. You have clear imaging findings. We have 3 categories of CSF leaks that fits for 95 to 99% of the patients, and we can treat it. We can treat it percutaneously with blood patching. You can treat it with embolization, and we can treat it by surgery. So to summarize, it's not a benign disease. It is best managed in centers that take care of these patients. Of course, it's rare. You need to build a service, probably 1 center in each country, and then you can spread the news. I always compare it to stroke. You need kind of a stroke center, a stroke unit with neurology, neurosurgery, and neuroradiology, and interventional neuroradiology. And you need the same for CSF leaks. You need dedicated people from neurosurgery, neurology, and of course, interventional neuroradiology. And then you need to build leak centers, because this diagnosis, as you will see by Thomas and Eike, is difficult. You need to have experience. And if you don't do it often, you can do a lot of harm. The X-ray dosages and the exposure to X-ray is quite tremendous. So I think you should build leak centers like stroke centers. And then it's easy. Then it's easy and then it's fun. And we also invite you, in Bern and in Freiburg, we always invite you to come to our places. We do 2 official courses each year come to Bern, come to Freiburg. We show you our cases. You can participate. And do not forget that headache disorders is the leading cause of abstaining from work and disability, from all neurological disorders, way more than stroke. And we can make an impact, and you can change the world of our patients. So thank you very much for having us again, and I'm very proud to be here. Thank you so much.